Hello, good morning, everyone. So I welcome you all to this session on Retina Essential for the General Ophthalmologist. We have a galaxy of speakers who will be speaking on different concerns which a general ophthalmologist has to face when dealing with patients with retinal pathologies. So we have Dr. Jayadev who will be speaking on screening the peripheral retina, how important it is before cataract surgery. We have Dr. Mallika Goyal who will be speaking on how to recognize and manage vein occlusions. Dr. Anisha who will be speaking on common macular pathologies you should not miss before cataract surgery. Dr. Neha who will be speaking on common posterior segment inflammatory conditions. Dr. Abhilasha Baharani, who will be speaking on cataract with uveitis, and Dr. Ashish Lal, who will be covering intravitreal injections, how anterior segment surgeons can add to their practice. And I'm Dr. Tinku Bali. I'll be speaking on diabetic retinopathy for the anterior segment surgeons, and OCT, what an anterior segment surgeon should know. So I request Dr. Chaitra Jaydev to deliver her talk. She'll be speaking on screening the peripheral retina, how important it is before
Thank you,
any anterior
Tinku. I
segment
think
surgery.
this is a very pertinent topic or set of topics that you have put together because we tend to miss it out when we are in a busy general practice and miss out important lesions which could have a bearing on the outcome of surgeries, be it cataract or refractive. So thanks for this opportunity and glad to be part of it for the second time in a row. I'll be speaking about how you need to screen, why you need to screen, and if you screen, what to look for in these patients. And as I mentioned, these are patients whom you are hoping to give 6/6 vision. You don't want them to land up in trouble. And in this litigious world, it becomes all the more important that you are aware of all the lesions that can cause trouble and you counsel the patients accordingly. I will be talking about a few peripheral retinal degenerations, when to treat, and recommendations for patients undergoing surgery. Well, let's look at a few important peripheral retinal degenerations. Every lesion, every pigmentation, every thinning does not really require prophylaxis. So, you know what degeneration is? It's loss of the structure and function of the cells in a tissue or an organ. But when you translate it to the retinal tissue itself, it's loss of structure or function of cells in the retina as we see it on indirect ophthalmoscopy or on imaging or on slit lamp based investigative devices. And then in the retina itself, you have peripheral degeneration and macular degeneration. Of course, macular degeneration is very easy to pick up, and I think Tinku is going to cover OCT, which is again a very objective way of looking at macular conditions. But here in this particular talk, we are going to look at all the peripheral retinal degenerations, how we check them, and how we address each of these lesions. Now, this is the classifications that basically looking at the location of the disease, which of them can give rise to what sort of pathology is also very important. A lot of these you would have already seen. So, they are vitreoretinal, intraretinal or chorioretinal lesions. They are important because they are usually located anterior to the equator, which means for someone who is not very comfortable looking at the peripheral retina, you can miss them. They can be associated with retinal breaks. They can develop retinal dynamic tears when there is a vitreous tugging on the retina, and all of these can predispose to rheumatogenic RDs. Now, that is particularly true for patients who are undergoing cataract surgery with pre-existing lesions, because a PVD that is induced even after an uneventful cataract surgery can give rise to these retinal tears and detachment, which is why when we are doing a final checkup for all our patients with cataract, we for sure do a dilated peripheral retinal examination, and we caution them of the symptoms that they need to look out and come back immediately. So, this is the snail track degeneration. It is very similar in appearance to a lattice. It has the same size, shape, orientation, location, and they can also be associated with retinal holes. So, they are not as innocuous as they look. We've just done OCT across these lesions, and we found them to have irregular retinal surfaces with some hyperreflective dots, which are basically lipids. Next, what is important is that vitreous, there is liquefaction that is noted over the snail track degeneration, but you don't see very dense vitreoretinal adhesions in snail track. Next, coming to the very important lattice degeneration. Here there is basically retinal thinning with loss of the neurosensory layer. Vitreoretinal adhesions are noted at the margin of the lesion, and it is seen in 6 to 8% of the general population. Most of them ask, why do I have it? Because these are the numbers. It's very common. It can be, it's usually cigar shaped. It is circumferentially oriented and located at or anterior to the equator. It is well outlined thinning with white crisscrossing lines. You can see them, that when you see those crisscrossing lines, it means those are lattice degenerations. They are seen also in systemic conditions such as Stickler syndrome. You can have a single lesion, multiple, you can see yellow deposits, you can see them pigmented atrophic holes, or retinal tears can also be seen. So, this is how you can see the vitreous adhesion over the lattice degeneration, as against nail track where you see vitreous liquefaction and the adhesion is not very strong. Now, coming to retinal holes, this is seen either isolated or with snail track or lattice degeneration. Here there is no posterior cortical vitreous separation in these eyes. So, you can have different types of atrophic holes. They could be operculated holes, which indicates that the cortical separation has occurred. There can be a cuff of SRF as well, as you can see in the last image there, or and important is that they can predispose to retinal detachment. Now, coming to retinal tears, these are dynamic lesions because there is a traction at the edge of the tear. This is how a typical horseshoe tear would appear, and these are cases which need to be lasered immediately because there is an ongoing pull and you do not want extension of the tear or a retinal detachment. Many times we have seen patients with these sort of HSTs in the OPD and we have lasered them and we have been able to effectively prevent retinal detachments. Then these are snowflake degenerations. These are basically fibrillar anomalies of the vitreous, and they include minute crystalline deposits resembling snowflakes, and that is why the name. There is no tractional changes by the vitreous in these particular lesions. They can be observed, they are innocuous, no laser required. Paving stone degeneration is seen in 25% of the population. It is a large number, most of us have seen it, it is very common. It is basically chorioretinal degeneration. They are well defined, they are yellowish to pigmented in color, and they are seen between the equator and the ora. Again, no predisposition to break formation or retinal detachment, no requirement to do laser for these patients. Sometimes I have noticed that our fellows get confused that this is a lasered peripheral retina and they tend to write status post barrage, but no, these are naturally occurring lesions. WWOP or white without pressure, again rather common. It looks the peripheral retina appears opaque without any depression. It is found in myopes, in elderly. Borders are ill defined. There is a slight or a small association with GRTs and retinal detachment can develop. So, maybe one can follow up these patients more frequently, does not require any prophylaxis again. Next, dark without pressure is not very common. You have seen white without pressure, but you can also see an area there which is dark. If you can see in the left of your image, I do not know if I can find my cursor, I can't. So, there are few other images here. This is dark without pressure. So, basically the differences are, this is dark without pressure is seen in the mid periphery. They are hyporeflective of the outer retinal layers and well defined and well demarcated compared to the WWOP, again does not require any prophylaxis. So, what causes RD in an eye with peripheral retinal degeneration? Well, it occurs because there is PVD. So, the main culprit here is posterior vitreous detachment. That is something your patients are going to come to you with floaters and flashes. You cannot ignore these patients because we tend to get irritated that they are saying this is moving, that is moving. People come with diagrams of the shapes of the floaters also. So, that is how distressed they are. So, do not take it lightly, examine them and re-examine them after a couple of weeks because PVD is an ongoing procedure. So, on the first visit if you have not seen a tear, it does not mean that the patient is not going to come back with an RD. Follow them up in the next 2 to 3 weeks and see if the PVD is completed without any incident, then patient is safe and so are you. So, they come with acute onset of flashes or floaters. It can, you will see some amount of vitreous hemorrhage. You may not be able to pick up the lesion on the first visit. You can do an ultrasound scan if the vitreous hemorrhage is dense or if the cataract is high. You will see a flap if there is an HST. You can even still pick up retinal tears on ultrasound even if there is no retinal detachment. Repeat the examination, like I said, 4 to 6 weeks later, process of PVD will be going on. And PVD with hemorrhage and pigments are more likely to have retinal tears already, if not developing in future. So, make sure you examine them a month later. When do you treat? Now, this is a patient, 26-year-old, has come with this lattice that I showed you for a routine examination. How many of you all will treat this patient if she has come for a routine examination? Show of hands, please. Okay, nobody is going to treat. If the patient is going to undergo surgery, will you still treat this patient or not? Anybody? Patient is undergoing refractive surgery, she's 26 years old. Okay, so we have a few people who've raised their hands. Well, to be on the safer side, yes, some low intensity barrage won't harm, but ideally this patient has a pigmented lattice, there is no clear hole seen, so may not always be required, and definitely not as a routine. Okay, so we don't have uniform guidelines for treating peripheral lesions, and not in the Indian population. Most of the literature that we have is from the West, so it may not be relevant, but I am sure all of you all will agree, with more and more medical legal issues, we need to be careful. We are basing our guidelines on academy and on Western data. We do not take into account difficult clinical situations. The same 26-year-old wants refractive surgery and she's one-eyed. I would laser. So you have to base your decision on an individual basis. You cannot just have a general rule. Everything changes from, and if she is married to a lawyer or her father is a chief justice, I would laser. So you have to take your decision. It is individual, it is beyond sometimes even clinical decisions. So suggested approach is, what is the lesion, what is the risk, what are the vitreous changes around that lesion, and what are the risk factors for the patient developing an RD. Decide based on that. Take a moment, think in your OPD even if it's busy, and then take that decision. Recommendations for screening and management. Also, why I am telling you to take your time to make that decision is because they won't go for a second opinion, they'll go for a fourth and fifth. And somewhere somebody will decide to laser that patient, they'll come back to you for follow-up and say, I've got lasered. So should we treat all patients? No, let me show you why. We collected some data of patients undergoing refractive surgery, more than 3,000 of these patients. Lattices were seen only in about 285, most of them did not have. And even though they did not have, one patient still developed a retinal detachment, if you can see from those numbers. But out of those who had lattice degeneration, 94 of them underwent laser. We did not have any RD, but laser not done, we did have any RD in any of them. So we did not have RD even in patients with lattice who were treated or not treated. So that's the important thing here. Though we are doing it to prevent, it is not necessary that all of them mandatorily need to undergo barrage lasers. So these are the recommendations. All symptomatic, asymptomatic HSTs, operculated holes, lattice degeneration with holes and atrophic holes, you will treat promptly. Irrespective of whether the patient is undergoing surgery or not undergoing surgery, this is mandatory. The others are all ambiguous. You can take a call based on the patient. Now, the next important thing is, when do I undergo surgery? If I have undergone laser, timing for surgery would ideally be wait for at least 7 to 14 days following laser. Retinal re-examination also preferably within 2 weeks post surgery. This is difficult for patients who come in the morning, undergo an optos examination because they want to undergo refractive surgery the same day and fly back the same day. So that's a challenge. So in these patients who come like that, I would suggest that you take it in writing that they want to undergo refractive surgery without barrage. There are patients who will say, I'll go back to my hometown and 2 weeks later I'll do the barrage. Still, you take that in writing for your own safety. And re-examination 2 weeks. I'm going to rush through this. I think I'm past my time. No, this is the last slides. So dilated retinal examination is necessary as part of a comprehensive exam. Let's not take shortcuts. These were refractive patients, a majority of them who have clear media. But for those who have peripheral cataracts, we may miss them on just imaging. Best to dilate and check all of them. Anybody who can do a peripheral retinal examination should be able to manage quite well. Most myopes actually have a posterior migrated ora, easily seen without depression. So please dilate and see. If you're not confident, then refer to a retina specialist. You can use even wide field imaging now, dilated better pre-cataract, thorough retinal examination for peripheral lesions, prophylactic barrage for all lesions which can predose at least a week before surgery, and irrespective of whether it's refractive or cataract, those with existing treated, untreated lesions, high myopes, sticklers, marfans, all of them will need examination post surgery once every 6 months to look for retinal tears, detachments and macular pathologies. Thank you so much.
Thank you, Dr. Chaitra. 2 points that you very well highlighted in your talk was that all lattice degenerations do not merit laser photocoagulation. And the second point that you brought out well was that never neglect the symptoms of the patient. Any patient coming back after cataract or LASIK surgery with floaters, no, you may not even have flashes, but floaters, please do a dilated fundus examinations, and many times you'll find a PVD-induced retinal break in the periphery.
Absolutely. Thank you, Tinku.
Any of the other panel?
Yeah, in high myopes, we often see that despite laser has been done for the various lattice and all, they still come with a tear, they still come with an RD. So just because laser has been done, a high myope is not safe. They should still, they should be told that if you have flashes, if you have any doubts, any veil-like floaters moving, you must come immediately. It could be a peripheral RD. The sooner we operate, the better. So.
Yeah, I had a question, ma'am. So the patients that you are mentioning, those who underwent refractive surgery, were they also having holes in the lattice, or it was plain lattice?
No, all those with holes were lasered.
Were lasered.
Were lasered. So we have a fixed protocol. So the minute most of our patients actually undergo undilated retinal examination on optos as during the first visit, because none of their scans can be done once they are dilated. The minute we see any lesion, we call them back for dilated retina. They all finish all their scans and come back to us. If they have holes, they are lasered same day.
Yeah, but if we go the other way, when we are operating an RD patient post any refractive procedure, and the lattice has a break at the edge which had no previous hole, so we know that happens.
Exactly.
Yeah,
So that's why when you're operating on these patients, I asked for a show of hands. I would still do, because we have seen lattices, even pigmented lattices, developing a break at the edge of the thing. But then usually they have either a surgery, that has happened, a complicated one, or even we do know that PVD is very common post uneventful surgeries also. So symptoms like Malika said, immediately they need to come back and we laser them promptly.
Dr. Taneja.
Personally, I think any lattice should be lasered with holes, because as you said, we see many non-myopes, non-risk factor eyes that come with a retinal detachment because there was a silent lattice with holes that had not been treated. So there's no harm in treating.
So we have a question.
My question is about that only. Can overdoing it be any detrimental? Can there be any side effect or complication of doing a barrage laser if you overdo it? So if not, then why not?
So there are actually two of them. One, when there's extensively barraged, you do cause release of cells into the vitreous, which can cause formation of an epiretinal membrane. So we don't need high intensity burns for barrages, but unfortunately it is done. And now that we have multi-spot, it's very uniform burns, and we do good ones without the incidence of ERM. There have been rare reports where there are actually PVD induction post barrage, when probably not done well, or I'm not really know the reason why. And the minute you disturb the vitreous, even before the laser has taken action, which takes at least 2 to 3 weeks, we've seen tears developing.
Yeah, so there is a very short story from LVP itself. So the patient had lost one eye to RD and had massive lattices in the other, and I was a fellow that time. So I asked my consultant that, "Aap hi laser kar do, it might cause trouble me later." And 2 days later, he had GRT in that eye. So I have seen it happening, and then there is too much of chaos. So you should at least counsel the patient. Now what I use in my practice is telling them कि अगर लिखा है 2 दिन बाद होना है तो हो जाएगा, but it is not because of my laser.
But we also need to understand the pathophysiology of laser. We are actually causing chorioretinal inflammation, and that inflammation is dying down and becoming a scar. So we are disturbing that vitreoretinal, interface thing. So once we disturb them in a young patient, we can actually induce changes which can have a PVD induction maybe after 6 months, 1 year or 2 years. So there are people, there is a school of thought which says that don't touch them. So we can talk about it and debate about it.
Yeah,
but I think what she has said, the algorithm and the protocols, I think we can follow.
The other thing is, if you've done a very heavy laser, sometimes that laser can weaken the retina and you can have a break at that point itself. So many times we've seen breaks developing at the edge of the laser itself, not because you've done the laser, the breaks develop.
And one more thing that I would like to answer is that we had a discussion with it in LV Prasad. A lot of people from Germany had come, and they said that what the doctors there were saying was that my son is having this, should I laser? My wife is having this. So when it comes to one of your close relatives, then again the question mark comes that can we disturb the thing or should we let it go?
On the intensity of the laser as well as on the extent. If there are an occasional lattice here and there, I don't think we have this discussion. We do it and it should be a relatively mild laser. The problem of causing an RD and all is very high if there is a 360 degrees kind of lattice and you've gone and done a barrage on the same day everywhere. Then there is a high chance of them coming back with a new tear or a detachment. So that also can be told to them beforehand.
So we'll take a quick question and then we'll move on to the next topic.
How frequently should these patients be followed up if they remain asymptomatic?
6 months at least. Initially 6 months, and then I do an annual checkup. So post-operatively, we keep expecting certain changes. Warn them of the of all the symptoms, the flashes and the floaters, any curtain, like there are people who've stayed with retinal detachments because they don't realize the field loss, because macula is intact. There'll be one small RD inferiorly. So 6 months mandatory, and if everything is fine and you are confident, once a year.
Thank you.
Also, after cataract surgery in a high myope, it's important to do a more regular screening for the first year at least, because that is the time when the PVD might actually happen. So
Yes. Thank you. So with that, we move on to our next talk. Dr. Malika will be speaking before because she has to go for another session, and she'll be speaking on how to recognize and manage vein occlusions.
Good morning. I'd like to thank Dr. Tinku Bali for this opportunity. I'll be speaking on practical management of retinal vein occlusions. So the first thing is to look for when we see a patient with vein occlusion, the first thing is to start looking for systemic comorbidities. Yeah, that's enough. Thanks. So look for systemic comorbidities. That is the most important thing. Hypertension, diabetes, dyslipidemia, and tobacco use. In younger patients, it's usually inflammation, homocystinemia, blood dyscrasias, thrombophilia like antiphospholipid antibody syndrome, and very important, which we do not ask, is medication, oral contraceptive pills or sildenafil. Now, when we are looking at a patient with RVO, very important to look for glaucoma. This is the most common ocular comorbidity. Look at the disc very carefully. Even the other eye, sometimes it's the other eye which is advanced glaucomatous disc. And once we know there is glaucoma, then avoid intravitreal steroid injections, and the glaucoma specialist should avoid using glaucoma medication, which can increase the risk of recurrent cystoid macular edema. Now, when we see a case of retinal vein occlusion, it can be based on its location, central hemiretinal, which is either superior or inferior, and branch retinal vein occlusion. The CRVO and HRVO can be ischemic or non-ischemic. Because of the large extent of involvement, these lead to serious ischemic complications. Branch vein occlusion can be a major vein or a macular branch vein occlusion. This is one of the commonest disease, non-ischemic CRVO, where the macular edema is milder, the presenting vision is relatively good, and they generally recover good vision with injections, though macular edema is often recurrent and requires several injections. On the other hand, the ischemic variety comes with very drastic vision loss, extensive hemorrhages, severe macular edema, or even if the macular edema is not severe, the vision is disproportionately poor because of ischemia. And even after treatment, the vision remains poor because of macular ischemia. More importantly, these patients, the hemiretinal vein occlusion is superior or inferior. Two quadrants are involved. The CRVO and HRVO, they require vigilance for neovascularization on the iris and neovascular glaucoma. So very careful examination of the undilated iris, angle with gonioscopy is very important. And this used to be happening in the first 3 to 6 months earlier, called 100-day glaucoma. But nowadays it doesn't happen initially because we start using anti-VEGF injections for the edema. So now we see these patients coming after 1.5 years, 2 years of onset, when the anti-VEGF has stopped. When we give up the injections, either patient gives up or we give up, or there is no more edema, then they come with neovascular glaucoma. And even non-ischemic cases of CRVO, HRVO can down the line progress to ischemic type. So they are not out of danger. Branch retinal vein occlusion can be one of the 4 major veins. The nasal BRVOs remain asymptomatic because macula is not involved, but they can lead to proliferative complications. So they need annual checkups. Now, initial complications are macular, which can be any of these. So the most common is, of course, the macular edema, which responds to anti-VEGF and steroid injections, but also macular hemorrhage. In chronic macular edema, they start developing epiretinal membrane, and even with treatment, they can go on and develop a macular hole with poor prognosis. They can present like this with an ERM and holes. And another problem is the hard exudates which accumulate when patient is not treated in the right at the onset. And these hard exudates, once they come, generally they cause permanent vision loss. So that is why, and most importantly also the cause is poor systemic control, uncontrolled diabetes or lipids, dyslipidemia. They need more intensive intravitreal injections, higher number of injections with greater frequency for resolution, and even with resolution they may leave behind permanent vision deterioration. Most important is systemic control, and prevention of these exudates is important by timely treatment. However, they do resolve, as I have shown in this picture here. When you neglect, it goes from 1 to 2, but after treatment you can have resolution. Other problem is ischemia. There may be no edema, but you can see the hyperreflectivity on the OCT showing ischemia. So vision is not good, but there is no edema. BRVO can also present down the line after few months with the silent new vessels on the iris, not on the iris, the retina or the disc, and silent vitreous hemorrhages or massive vitreous hemorrhages. So every BRVO needs annual checkup, even if vision is good. That has to be emphasized. And timely treatment, for example, NVD seen in this patient, we can do a scatter laser in time and prevent blindness. So annual evaluation has to be emphasized, lifetime annual evaluation. These are patients who did not have any symptoms, but they came for their annual checkups. And you can see the vitreous hemorrhages, NVD, NVE, and timely scatter laser was done. And this is how it regresses. The NVD has regressed with. Often we may have to extend the laser not only to the involved quadrant, but also adjacent quadrants. And many times if the ischemia is severe enough, we have to do a complete pan-retinal photocoagulation, even in a BRVO. They can come like this with their end-stage disease, tractional retinal detachment. So surgery followed by good scatter laser during surgery itself. Macular branch vein occlusion is a localized affection, so there is no proliferative complications, but the macular edema can be very recurrent or resistant to treatment. Imaging in retinal vein occlusion, multimodal imaging is required with all these modalities. The OCT shows us not only edema but also ischemia, the hyperreflectivity that you see. Photographs are very important for capturing exudates, hemorrhages, which are not captured by the OCT that well. If you see this patient over 5 years of treatment, OCT has remained the same. So patient would think that there is no improvement with treatment. But if you see the exudates have resolved. So the treatment has helped the patient, and that is very important to document. OCT angio has become very important to see macular ischemia, or even it picks up new vessels on the disc or elsewhere which was not expected. However, OCT angio cannot show us the leakage which we need to see for doing laser, macular laser. Now, this patient was being treated with a lot of injections outside, but diagnosis was not clear, whether it is a succinate diabetic maculopathy or a BRVO or a macroaneurysm. So fluorescein gave us a diagnosis. There was a quadrantic hypoperfusion superior with collaterals showing a superotemporal BRVO. So we now know where to laser for the exudates. Octa could not show this because the patient of motion artifacts. And Octa also becomes relatively useless when the media is opaque. Fluorescence still gives us some images. So this is where to do the laser for the exudates. Again, patient with exudates, not sure what's going on, and angiogram shows us where is the leakage, inferotemporal BRVO with leakage. So that is where the grid has to be done. It also throws up new vessels, which we may or may not have expected in an opaque media, and also shows new vessels on the iris with leakage. So fluorescein has advantages over OCT angiography in patients with opaque media especially. Treatment, serial anti-VEGF injections are the first line treatment. There's no timer that I see here. Okay, 20 seconds. Is it showing somewhere? Okay. Okay, not to us here, okay. So anti-VEGF injections are the first line of treatment and have good response. These are the various anti-VEGF injections and steroids. Steroids are second line because of their major side effects. Dex implant can migrate into the anterior chamber if there is a large opening as a scleral fixated IOL. As you see in the picture on the second from right, that's my own patient, scleral fixated IOL, and it can cause a corneal decompensation with very high IOP. This we were able to remove in an emergency, and the patient was doing well. So when do we use steroids? Only when there is inadequate response to anti-VEGF, or where anti-VEGF are contraindicated, absolutely in pregnancy contraindicated, or recent cardiovascular events, severe renal dysfunction, or where there is some traction which can get worse with neovascularization. Laser is recommended only for branch retinal vein occlusion after doing an angiogram. This can give some long-term benefit and reduce the number of injections required with time. However, it is not recommended for CRVO or related CME. There we only need a pan-retinal photocoagulation for new vessels on the iris, angle, or elsewhere. So follow-up for any case of RVO every 6 to 12 months is mandatory with intraocular pressure, undilated slit lamp exam, gonioscopy for angle new vessels, and very, very important, fellow eye, because many times the other eye also has a vein occlusion which is sitting silent but with proliferative complications which will lead to blindness. If there is a disproportionate vision loss with CRVO, look for this kind of whitening in the center, which is a cilioretinal artery occlusion. This reduces the prognosis because macula becomes ischemic. So even with anti-VEGF injections, the visual prognosis is poor. And this is the last slide. RVO in the young behaves very differently. It is often idiopathic, though there could be blood dyscrasias or medicine use. Generally, the vision is good at presentation also, and the macular edema is mild, and usually one anti-VEGF is enough, one injection is enough. They do not require repeated injections. Good visual prognosis. Thank you.
Thank you, Dr. Mallika. So I invite questions from the audience, if any. What you very well highlighted was the importance of follow-up in these patients. So many years down the line, there'll be a lot of sequelae. These patients generally come back with vitreous hemorrhage if they are not tended to. So please follow up the patients and do emphasize that to the patients of any vein occlusion.
So we move on to our next talk.
One question, I think.
Just wanted to ask you, when do you plan a PRP in a case of CRVO? Only after you've seen the new vessels on the iris, or should you do it when the patient first comes to you?
No, not first comes to you, because the CVO study, which was done several years back, has shown that it should be done only when new vessels are seen. In fact, they showed that if it is done before NVI develops, then it in fact does not do any benefit and may not prevent NVI for some reason. And then you are reducing the field of the patient further with PRP. So I think there should be a definite indication in terms of NVD, NVE, or NVI.
So you just keep these patients on follow-up unless and until you see something?
Yes.
Thank you.
Thank you.
Thank you, ma'am.
Do you routinely recommend testing homocysteine levels in all patients of venous occlusion? And if you find that homocysteine levels are raised, what additional thing you need to do?
I do advise for all patients, even elderly patients, because many of them do have on the higher side. What we do start is homocheck, which is a combination of various vitamin B complexes, which reduces the homocysteine level. Plus there is a diet schedule which is low meat, low methionine, high in fruits and vegetables, which is advised to them, and more of exercise. So there is that diet, if you read up, there is a diet schedule which you can give them, and then their homocysteine at 6 months comes down, you can stop it. It does increase the risk of, because in some patients that is the only risk factor which comes out positive.
Thank you, ma'am. Our next talk will be by our chief instructor, Dr. Tinku Bali. Dr. Tinku is a renowned retina specialist, and she's working as a senior consultant retina in Gangaram Hospital and Delhi Eye Center. And she has been a very active member of AIOS and a member ARC North. So she's going to talk about OCT, what an anterior segment surgeon should know. Over to Dr. Tinku.
Good morning, everyone. So I'll be giving you some pointers on how to interpret an OCT. Well, an OCT is a non-contact, non-invasive diagnostic modality which has revolutionized retinal disease management, and it gives us high-resolution images of the posterior segment, almost like an optical biopsy. And the OCT layers, they correspond very well to the layered retinal anatomy. The resolution of the OCTs have been increasing over the years, and now we also have 3D rendering. So when you get an OCT printout, there is a quantitative analysis here where you get the central macular thickness and also the thickness parameters of the perifoveal areas. And the qualitative analysis wherein you study the different retinal layers. Now these layers are better delineated in the black and white scans and not in the colored printout. So always make sure that you have the black and white printout or the black and white OCT on your screen, which highlights the layers much better. So these are the different retinal layers. The layers which are of concern to us are the retinal pigment epithelium here and the ellipsoid zone here. So the ellipsoid zone has been variously called different names. It was earlier called the ISOS junction, then it was called the photoreceptor integrity line, and most recently it is called the ellipsoid zone. So there are a lot of new terminologies that keep coming in. There's the interdigitation zone, there is the myoid zone, but generally these are the two things that would be of concern to us. Now, break it down to the basics. So you see the inner retina, this is the inner retina, and this is the outer retina. The part facing inside is the inner retina. The outer retina is the area which is generally affected by choroidal vascular diseases, and the inner retina is the area affected by retinal vascular diseases. Many times when we see the OCT, it's not that we have to look at it layer by layer. Sometimes pattern recognition just helps us to diagnose the condition. So here you see this intraretinal fluid which is speckled. Here you see an asymmetric edema. You see that suddenly there is this rise here. Here you see large cystoid spaces, intraretinal spaces. You see some subretinal hyperreflective material here and subretinal fluid here. This is a pigment epithelial detachment with intraretinal fluid, subretinal fluid, and hyperreflective material. So just by seeing these patterns you can diagnose. So this is a normal OCT, this is diabetic macular edema, this is a branch retinal vein occlusion where you see this asymmetric edema. These large cystoid spaces are post-CME, inflammatory CNVM, and wet AMD would present like this, large PED, subretinal fluid. So many times you can just see it and make your diagnosis. So once more I'll come to the anatomy and explain the layers to you. So if you start from here, this is the choroid. This is the retinal pigment epithelium. This is the ellipsoid zone that I just mentioned, and this is the most important to us, and this would prognosticate the vision of the patient. This is the external limiting membrane. Again, the external limiting membrane goes hand in hand with the ellipsoid zone, and both these have visual, they have implications for the vision of the patient. After that, you have the plexiform layers and the nuclear layers here. And this is the nerve fiber layer here, this one. So like I said, most of the times we'll be looking at the RPE and the ellipsoid zone. This is the ganglion cell layer. So these are the different layers that you should be familiar with. Now, many a times people are not able to diagnose whether this is subretinal fluid or pigment epithelial fluid or a pigment epithelial detachment. So the way to do that is to just follow the retinal pigment epithelium here. So you see the pigment epithelium here is continuous, but here you see the ellipsoid zone, the external limiting membrane are rising up here. So this is a subretinal fluid and not a pigment epithelial detachment. This is a pigment epithelial detachment where you see the RPE itself has risen up and you can see the ellipsoid zone here. So this is a pigment epithelial. This is a combination. You can see a combination. This is the pigment epithelial detachment and this is the subretinal fluid here. This line here under the pigment epithelial detachment is the choroidal layer. So this is how you would diagnose a subretinal or a... So to the audience, is this a subretinal fluid or is it a pigment epithelial detachment? Anyone? Subretinal fluid, because the RP is intact over here. This one? This is subretinal because you see RP is intact, and here this is subretinal and this is some hyperreflective material here under the retina. Now, another thing that you can, just an interesting thing that you can make out from the OCT is whether this is the OCT of the left eye or the right eye. So the nerve fiber layer here, this nerve fiber layer is thicker near the optic nerve. So this OCT scan, just by looking at it, even if you don't know which eye, would be of the left eye. Now, once you get an OCT, you first determine the overall scan quality. So the scan quality has to be good for you to analyze all the different layers. Make sure the patient doesn't have a dry eye. Sometimes if the patient has a cataract, you can do it from the periphery, the scan, if the if a central cataract is there. Make sure that the lens of your OCT is clean. You can clean it before you take a scan. Reading an OCT is like reading an ultrasound, where superficial structures will affect the underlying tissue. They cast a shadow. So here you see this structure in the vitreous is casting a shadow here. These are small vessels near the disc, so you will often see such shadows on your OCT, and these are nothing but vessels which cast a shadow. So this is again shadowing to show you. And here you see where there's an area of atrophy here, you see the choroidal layers are more prominent. Okay? And where there's shadowing, you cannot see the choroidal layers. After that, quickly see, whenever you're seeing an OCT, you quickly see the overall scan profile. How is the retina? Is the retina detached? Is the pigment epithelial detached? Is the retina thick or is it thin? This is all what you see first. So this is a case, I'll just quickly show you a few conditions. So this is a patient of wet AMD. You see the pigment epithelial detachment here. You see some subretinal fluid here. You see these hyperreflective dots, and this is hyperreflective material under the retina. So this hyperreflective material in the initial stages is amorphous. It is, got fuzzy margins, but once you start treating the patient, it becomes more delineated. Its margins become more defined. This is a CSR, a very common condition that you'll often see. So again, pigment epithelial detachment, subretinal fluid. Branch retinal vein occlusion, there you see shadowing of all the layers here because there's hemorrhage here. So all the layers here under this are obscured by the blood or the fluid. So this is shadowing. This is intraretinal fluid here, and there's some amount of subretinal fluid here. This side, like I said, an asymmetric edema. A BRAO, just by looking at this picture, you can say that this is a BRAO because you see this hyporeflective area here. This is very characteristic because of the ischemia in BRAO. It is not present on this side, it's present on this side. Now, thinning would appear like this. This is the normal retina, and this is the area which is thinned out. So you can, and here you see there is a loss of all the anatomy in this case, so that those patients would not have good vision. After that, you evaluate the foveal profile. This is how the normal foveal contour looks like. Now, this is something called, this is the foveal pit, and it can have varying morphologies. It could be a little deeper, it could be a little, less deep, but both these patients would have good vision. Also, there's something called the foveal peak over here. This is a very normal structure. So this is present normally in a lot of cases. After that, see the foveal profile, where the fovea is distorted or not, whether there's a macular hole, any membrane on top of the fovea, and make sure you have a foveal cut. So many times patients who have macular pathologies are not able to fixate on the light of the OCT. So it's a good idea to turn off the room lights, ask them to occlude their good eye, and make sure that you have a cut right through the fovea itself. So in the structural assessment, you look at the posterior vitreous, look at the OCT layer by layer, look at all the layers now. So identify any abnormal structures that you have. You can see the vitreous here on the OCT very clearly, and you can see whether there's any abnormal attachment or an adhesion. So this is a vitreomacular traction. That was a vitreomacular adhesion. A traction would distort the retinal layers. An epiretinal membrane causing a lamellar hole here. Diabetic macular edema can have the spongy pattern, a cystoid pattern, a serous detachment like this. And most important, when you're assessing a patient of diabetic macular edema, see the vitreoretinal interface, whether there's any taut posterior hyaloid and epiretinal membrane over there or not. Now, the ellipsoid zone, as I mentioned, should be continuous throughout, and this has a direct correlation with the visual acuity. Here you see there is disruption of the ellipsoid zone. The external limiting membrane is intact, but the ellipsoid zone is not, and this patient would not have a good visual acuity. Pigment epithelial detachment I've already talked about. So enhanced depth imaging is now available in a lot of OCTs where you can see the choroidal layers more clearly, especially in pachychoroid diseases like CSCR. You see that the choroid is much more thickened. Now for the audience, what is this? This is something causing shadowing behind. Any guesses? So this is a large pre-retinal hemorrhage, and you see this is the shadowing of the layers behind. Pitfalls in the OCT, so you do not compare the thickness from two OCTs. Every OCT has a different cuts, so the spectralis takes the thickness of the macula from the ILM to the posterior edge of RP and the cirrus to the anterior edge, so you cannot compare the thickness between two OCT scans. That is very important. Look at all the images. When you see all the cuts, see all the images. Do not look at just one scan. So this was my optometrist who came with this. I thought it was a CSR or some a retinal detachment, but the patient actually had a BRVO. So if you've not got the correct cut, you will not be able to interpret. Don't rely only on the thickness scans. Please have a look at all the different scans and they'll give you a lot of information. So in conclusion, OCT is a very important tool which helps us to diagnose, prognosticate, monitor the follow-up. It should be done on all patients, if possible, undergoing cataract surgery. Many times you'll pick up epiretinal membranes or macular holes, lamellar holes, which you could not identify clinically, and also use it as an educative tool for patients to show them these pathologies. Thank you.
Thank you, Dr. Tinku, for a very elaborate and very simplified presentation. Any questions from the audience?
Can thinning in general be a pathology? I mean, will it have a bearing, especially in the fovea region?
Yes. So generally when thinning,
and why would it happen? I mean, patient does not have any pathology as such.
So there are certain genetic diseases, certain degenerative diseases, some macular dystrophies which would cause this kind of a thinning, drug toxicities which would cause this kind of a thinning. So thinning on OCT would have a bearing on the visual prognosis.
So we move on to our...
Yes.
Yes.
So around 200 microns in the Indian, for the macula. For glaucoma, it would be different, like for maybe 100 microns, 120 microns would be the normal thickness. Yes, superior is thicker, but...
So...
Ma'am, I'm a PG student, so I have a very basic question, ma'am. Ma'am, how do you differentiate, like in OCT you said, how to differentiate by seeing the thickness for which side of the eye that OCT belongs. So if that patient is having thinning in that specific area, then by one cut, how can we differentiate that?
No, that was only for the nerve fiber layer. By looking at the thickness of the nerve fiber layer, you can make out which eye it is. Nasally it is thicker and temporally it is thinner. Just the nerve fiber, the topmost layer, that's it, not all the layers.
Thank you, ma'am.
So we move on to our next speaker, Dr. Anisha Gupta, who is the director of Excel Hospital and a retina consultant at Max and Fortis Hospital. She is going to talk about common macular pathologies which we should not miss as a cataract surgeon. So what all common macular pathologies we need to look before doing the cataract surgery, one of the very important pertinent topics. Over to Dr. Anisha Seth.
Good afternoon, everyone, and thank you for being such an excellent audience. Thank you, Dr. Tinku, for a very engaging talk and making my talk easy, because OCT is eventually the backbone of diagnosing all the macular pathologies. Sorry, it's not starting. Yeah. So macula is why this topic, because macula is the key to visual outcome after cataract surgery. It plays the most crucial role, no matter how advanced we become in the form of machinery, IOLs, or technique. If the macula is not supported, the patient's visual outcome will not be very good. Also, the choice of intraocular lens would largely depend upon the macular health. If the macula is already compromised, we do not recommend going ahead with a trifocal lens, or even in some cases, any EDOF lenses. So coming to the very basic, how to detect a macular pathology. And there we have our very own old age-defined 90-day examination, which will tell us if macula is healthy or not, and an indirect ophthalmoscopy to see the overall health of the retina. Look for very subtle signs. A dull FR, the FR is not looking very nice, the foveal reflex, an unusual pigmentation, a different coloration, a smallest of retinal hemorrhage, an unusual sheen over the macula, any atrophic patch or a scar that you see, do not ignore it. And the crux of the matter, consider a macular pathology if the vision loss is disproportionate to the density of the cataract. So for example, there's a grade 2 NS, but the best corrected visual acuity is only finger counting 1 meters. Just think because there has to be something else. And of course, as Dr. Tinku mentioned, OCT is eventually the key for diagnosing of all macular diseases. Go ahead with an OCT with the slightest of doubt. Coming to the most common condition that we all see in our practice, diabetic macular edema, because of course in India, diabetes is like rising really much. And in all the patients in diabetics, the cataract is also seen more frequently and earlier. So whenever you have a patient of diabetes with cataract with more than 5 years of history, look more intently for signs of diabetic retinopathy, as this DME is easily missed in early stages. Look for any sorts of microaneurysms. Hard exudates are still easily seen, but subtle, small edemas you may still miss. Go for an OCT, preferably. And the OCT, you will see, if the OCT is normal, well and good, you can go ahead with the surgery. But in case it's not normal, it might show a DME or a macular thinning. Either ways, you have to prognosticate the patient. It may just show signs of photoreceptor damage as in sign of ischemia. So something like this, if you get on the OCT, you see macular edema, you see hard exudate, don't just rush into cataract surgery because this is what is going to modify your plan of action. Because here you will have, this will affect the post-cataract visual outcomes. This will require treatment before or adjacent to the cataract surgery. So either in the form of anti-VEGF injections or steroid injections in collaboration with the cataract surgery, and also you have to counsel the patient that post-op also the patient will require more treatment. Starting NSAID eye drops pre-surgery is very important, even if you have slight amount of edema. And sometimes focal laser is also helpful if you find very nice focal leaks before doing a cataract surgery. It's very important to know that a case of DME missed pre-op may actually increase extensively post-surgery, leading to no gain or even fall in vision. So a fundus like this, where you don't see much hard exudate or hemorrhages, there is a slight front on the disc if you can make out, and the OCT is showing a slight elevation on the nasal side. Now this kind of a patient after cataract surgery, the traction might suddenly increase, the macula might go off, and the patient will lose vision. Coming to the second important topic, old vascular occlusions. Why old? Because the new ones are anyway glaring into your face. You see a lot of retinal hemorrhages and specific signs. But the old ones you definitely will miss. So look for signs of pale disc, pigmentary changes, any single retinal hemorrhage, occluded vessels, and of course collateral formation. So this patient came to us with a vision of 636. Cataract was definitely there, but if you see in the inferior quadrant here, you see some collateral formation. Did an OCT, and here we have inferior area CME. At the center also there is the CME. Now this patient, if I had rushed directly into cataract surgery, would not have gained much vision. So again, in a patient of vascular occlusion, the patient may show a macular thinning or an edema depending upon whether there's ischemia and how much it is. And both of these will limit the visual recovery after cataract surgery. So it's important both for management as well as prognostication of the patient. And if there's a CME, do treat the CME before or along with cataract surgery. Coming to the third disease, AMD, because cataract and AMD both are age-related, we are going to have a lot of patients who have both. So when it comes to dry AMD, the diagnosis is very much clinical. You see those yellow drusen's lying on the retina and you know what it is. Problem occurs when there's a wet AMD. So with wet AMD, many times you may not find hemorrhages all the time, and there could just be a slight amount of exudation. So this patient came to me with finger counting 2 meters, history of 6-8 months of vision loss, and there were not much hemorrhages on the fovea, but I could see some exudation. Going for an OCT, we saw a large subfoveal CNVM with a lot of edema, and of course this patient is not going to gain vision after cataract surgery, no matter what I do. So you start the treatment. It's important that you tell the patient it's going to be a chronic treatment pattern, and the patient is going to require injections later on also. And how much vision improvement there's going to be, we don't know. ERM is a very common disease, may not require treatment at all the points, but this is also age-related. Look for a grayish, yellowish membrane over the macula. The discoloration is the key point. And the second thing is you might find the vessels being pulled or straightened. So these two signs will give you the indication. And if there's an extensive ERM, you have to go for a combined surgery, involve a retina colleague, and only then, because the cataract may not help. Macular hole is very much visible clinically, whether it is full thickness or lamellar hole or it requires treatment. Again, if it requires surgery, consult a retina person and a combined surgery is the better approach. CSR, although not very well seen in older patients, it's more of a young patient disease, but whenever you see a CSR or an NSD in an older patient, try to look for a CNVM because that might be hidden somewhere. So if that is the case, you have to treat the CNVM as I told before. Very important topic, a MACTEL or a JFT, because here you will see an absolutely silent fundus. You will not see much, maybe here one or small reddish lesions or small patch of black pigmentation. But these patients, once you do an OCT, you will find a lot of findings. You might find loss of ISOS junction, you will find an ileum drape or a foveal thinning. And here you have to tell the patient, because you do a cataract surgery, but the patient may still lose vision eventually because it's a progressive disease and may form a CNVM later on. Coming to some rare macular pathologies, photic injury, a history, you can ask, old trauma, again, you don't know, but subtle signs like a pigmentary change at the macula will be the giveaway. So, and again, suspect all these, and another cause if vision loss is just not proportionate to the cataract. Cataract surgery has to be done, but this is basically for prognostication, because only when you tell the patient and you keep the expectation low, the patient will thank you for the surgery, otherwise you're going to be in trouble. So to conclude, a thorough macular evaluation is essential before cataract surgery. OCT is the gold standard for diagnosis. Identifying macular pathologies ensures better patient expectations and outcome. And even a perfectly done cataract surgery may fail if macula is not supportive. Thank you very much for your time.
Thank you, Dr. Anisha. So any questions, I invite you.
So Dr. Anisha, you mentioned that we should start NSAID before the surgery. How long before the surgery and what are the indications? Where all would you start before the surgery?
Sir, for a diabetic patient, it's always better to start if the patient has any form of retinopathy and even if the macula is dry, about preferably 2 weeks, but if not, you don't have 2 weeks, at least a week before. You start some NSAID prior to surgery because this has shown to reduce the incidence of post-op CME, because even if the macula is dry pre-op, in these patients, post-op CMEs are very much known, even if the surgery has been uneventful. And one, if the macula is dry, and second, if there is very slight amount of extra macular edema somewhere or very little cystoid spaces, you can start NSAIDs because that is going to reduce the chances of the increase in CME. Of course, if there's a gross CME, you have to treat with either a steroid injection or an anti-VEGF injection.
I mean, a patient without any diabetic retinopathy.
Still, you should, because studies have shown that the chances of post-op CME developing later on after cataract surgery is reduced with starting NSAIDs pre-op.
And what about the post-op NSAID? What is the guidelines on that?
Post-op, again, it should be given. I prefer to give it for at least 6 weeks, although we are also giving post-op steroids to these patients. But 6 weeks, yes, I definitely give. And because if the CME has to develop, it's going to develop in those 6 weeks' time.
Okay. Thank you.
Hello, doctor. I want to ask if we do laser photocoagulation for diabetic retinopathy or for venous occlusion, then after how many times we can plan for cataract surgery?
Ma'am, you mean to see the peripheral PRP and sectoral
Yes,
PRP?
yes.
It should, because all the lasers, they normally take 6 weeks to 12 weeks for whatever, because if you're doing a laser, there has to be a neovascularization, a proliferative disease. So we need to let it work. It takes about 3 months for the NVs to ablate. If the patient can wait, that is the ideal time period to wait. Once the ideal is that you perform an FA after that to see that the NVs have regressed, because the purpose of doing all that is so that the bleeding doesn't occur post-cataract surgery. If the cataract is aligned with the laser, then do the laser, wait for some time, do a repeat FA, and then plan the cataract surgery.
You said that macular edema or macular thinning should be treated before cataract surgery. So edema, I understand. There are some cases where you do not find any other retinal disease but macular thinning. So in these cases, if you want to do cataract surgery, what treatment do you do in macular thinning?
There is no treatment for macular thinning, but you have to inform the patient. You have to give a guarded visual prognosis. That is very important, that your vision may not be as great after surgery. So if there are no more questions, we'll move on to the next talk. So next we have Dr. Neha Mohan. She is a vitreoretina consultant at the JNI Hospital, Mohan Eye Institute and St. Stephen's Hospital. She trained at the LV Prasad Eye Institute. And apart from retina, her other special interest is uveitis. So Dr. Neha, she'll be speaking to us on common posterior segment inflammatory conditions.
Good afternoon, everyone. So at the outset, I would like to thank Dr. Tinku for giving me this wonderful opportunity. So uveitis being a relatively difficult topic. So whenever we are seeing a patient of uveitis, the first thing that comes to our mind is, what kind of uveitis am I dealing with? And secondly, what is the best treatment for the disease? We are always worried whether the disease is infective or inflammatory, because the treatments are totally opposite. So we know the sun classification, and today we would only be discussing something that happens behind the lens, that is intermediate, posterior, and panuveitis. So intermediate uveitis, a patient would generally come to you, with bilateral involvement in 70 to 80% of the cases, which may actually be asymmetric. And when you look into, you will see some vitreous haze, and inferiorly you can see some snow banking and snowballs, or actually the patient may be having only CME with few cells on the anterior vitreous face. So these little signs need to be picked, because sometimes the cataract surgeons are in too much hush. They see nuclear sclerosis 2 and 3 and plan a surgery. I think a detailed AC examination and an anterior vitreous face examination is important to pick any cells. Otherwise, post-cataract surgery, you get inflammatory surprise and you wonder why the patient, without any eventful thing in the surgery, is showing so much amount of inflammation. So you should always grade the vitreous haze when you are seeing it in a patient, and this actually is helpful if you are doing a photographic documentation of the same, because when you treat, it is very easy to tell whether the patient is responding or not. But wait a minute, just vitritis doesn't mean intermediate uveitis. So if you're seeing some cells on the anterior vitreous face, there are other diagnoses that need to be considered, which are even more sinister, like acute retinal necrosis, toxoplasmosis, and endogenous endophthalmitis. And the point is that the treatment of these three is totally opposite to that of intermediate uveitis. So in ARN and toxo, which we'll take later, you have a focal retinal lesion, but you have to look for it carefully. And in endogenous endoph, you will have a history where the patient will tell you that he took some intravenous fluids. Treatment of intermediate uveitis, earlier, we used to go oral steroids and then local steroids, and then immunomodulation used to come in the end. But now our tolerance to cataract and glaucoma has really gone down, and we start immunosuppression quite early once we have ruled out infective causes like tuberculosis. So when you're looking at a patient and you see something there, that's the word, there is something, you need to know whether that something is active or healed. That is the first thing that you should aim for. Any active lesion would have a yellowish white border, and vitreous haze may be associated with it, with fuzziness of the borders. While it is healed, the margins get sharp, and there may or may not be a pigmentation. So this differentiation to know is very important, because sometimes if it is just an RPE defect that you are seeing, you can prognosticate and go ahead with your cataract surgeries and everything. But if there is anything cheesy, you see some yellowish thing there, you definitely need to investigate the patient further. The second differentiation is between retinitis and choroiditis, because retinitis would be more superficial. It would be obscuring the underlying vessels. They can be hemorrhage associated. While choroiditis would be more deeper, and the margins would be relatively sharper. Why do we need to differentiate? Because retinitis is usually infective, and you need to give specific antimicrobial therapy for that. While in choroiditis, if you have some experience with uveitis, you can go ahead with steroids and immunomodulation. So just touching few diseases, ocular toxoplasmosis, we know that it would be a yellowish white lesion next to a scar. And if it is the first episode, you would see a yellowish white lesion just right at the posterior pole somewhere. Treatment is with cotrimoxazole along with plus minus oral steroids. Acute retinal necrosis, when you would see the periphery, you would see some circumferential pattern of yellowish white necrotizing retinitis, and it's usually in immunocompetent people. And treatment is with Valsivir, 1 to 2 grams depending upon the quadrants involved, and with plus minus steroids. Syphilis being the biggest masquerader in eye, anything in eye can be syphilis. So whenever dealing with uveitis of any kind, always get a VDRL or a TPHA done before just progressing with oral steroids or immunosuppression. And the treatment of syphilis is actually very simple. The disease just melts down with benzathine penicillin or with ceftriaxone in case of any hypersensitivity to penicillin. Coming on to CMV, so if it's a typical HIV patient, you would see that brush fire appearance, and you know that, it looks that even if the patient is not diagnosed with HIV. But now sometimes these patients of psoriasis or other organ transplant who are on immunosuppression, like azathioprine, they can actually show CMV retinitis. And usually the form is granular variety where you don't have much hemorrhages. You can also see the frosted branch angiitis variety of CMV, but frosted branch angiitis is just not CMV. There are other diseases also where you can see this. So choroiditis is little subtle and has less specific patterns because it is behind the retina. So the three main patterns there we are going to touch is the infective choroiditis pattern, like the serpiginous one, which is usually associated with ocular tuberculosis, and you see the serpentine pattern with irregular margins. Autofluorescence very well picks up the activity, and the hyperreflectivity you see is active choroiditis. Similarly, choroidal granuloma is also usually infective. And when you do an OCT, this is typical tubercular granuloma where you see the contact sign. The granuloma is actually pressing upon with some neurosensory detachment. These patients usually require ATT along with oral steroids. The non-infected type of choroiditis patterns can be APMPP and mutes. The mutes, this is like the typical wreath pattern that is spoken about, and luckily they are self-limiting, or sometimes you may need oral steroids. Coming on to the non-infectious pattern with systemic disease, the sarcoidosis being the most common. So if you're seeing these depigmented lesions in the inferior retina, you only have two diagnoses in your mind, either it's sarcoid or it is VKH or sympathetic ophthalmia. And then you look for other signs like lupus pernio, or you get a CECT chest done and you see this hilar lymphadenopathy. You know you're dealing with sarcoidosis, and that's how you go about with your treatment. So there are many differentials. Supposedly you see something like that. This is not choroiditis always. A simple thing like CSR with fibrin can also look like choroiditis, and posterior scleritis is also pretty common. So you need to differentiate, and I think here comes the role of angiography, and no other investigation is going to help you with that. Retinal vasculitis, there are multiple reasons. So the main thing is that we should recognize that this is vasculitis. You should see perivascular cuffing with some irregular margins, and you need to note down which vessel is involved. Is it primarily arterial, venous, or both? Is it a skip vasculitis? You can see here where it is not continuous, while sometimes it is a continuous vasculitis. You need to see whether they are hemorrhages, because that's usually associated with occlusive kind of disease. Here, when you do an FA, you see they're completely, we see the capillary non-perfusion areas. And we also need to check systemic things like oral genital ulcers, which are usually associated with Behçet's. So just to mention about Behçet's, we have mobile hypopyon there, and this ferning pattern which we see typically on FFA, and Behçet's require an expert treatment, so we should better hand it over to the expert. The last disease that I'll talk about is VKH, which is the most common cause of panuveitis. It is actually not that rare, and when we see this typical blister-like detachments at the posterior pole, you see it here, and you do an OCT. This is the typical OCT with multiple neurosensory detachments. You should not miss that this is VKH. So we will see hyperreflective dots, happy undulations, multiple neurosensory detachments. When you do an FA, you see the starry sky appearance with late pooling. These multiple pinpoint leaks, that's a starry sky appearance, and this leakage, that's the pooling of the dye in the late frames. In acute phases, there can be different presentations like angle closure, exudative retinal detachment, or only disc edema. So disc edema, if you've ruled out all other causes, VKH is also one of the causes. If not appropriately treated, the patient progresses to chronic stage where we see the sunset glow with the hyperpigmented lesions we saw in sarcoidosis. We can see simple RP hyperplasia, and we can have recurrent granulomatous or non-granulomatous inflammation. So how do we stop a patient from going to acute To chronic stage, only one thing, early immunosuppression. Please do not wait for a second episode of VKH to start your immunosuppression. So I hope I have not complicated things for you, and thank you.
Thank you, Dr. Neha, for making it so concise. It was a very vast topic, I know. So, any questions? So,
I'll just add a few points. Very good presentation, Dr. Neha. About the vitritis part, many a times we see old patients who come with cataract and vitritis. In older individuals, try to rule out masquerades like lymphoma. These patients may have vitreous cells, which are actually lymphoma cells, and even with significant vitritis, they don't have CME. So that is one thing that differentiates from lymphoma from intermediate uveitis. And one more point about sarcoid uveitis, always look for a dry eye, do a Schirmer's test. Dry eye is more common in sarcoidosis compared to TB. Otherwise, it's very difficult to differentiate the two conditions. So this is just one more point. Thank you.
Thank you, Dr. Abhilasha. I request Dr. Mohammad Abdul Wahab Al Amri. Sir, are you there in the audience? No. So we had a keynote address, but I think Dr. Wahab is not there.
Our next topic would be diabetic retinopathy for the anterior segment surgeons. By Dr. Tinku Bali. She had very nicely explained the OCT, and now she's going to give you the tips and tricks of how to deal with diabetic retinopathy and the cataract together. Thank you.
So I'll just be covering diabetic retinopathy, not cataract with it. So just a few pointers. We know that diabetes is now, rampant in our country and over the world. If diabetes was a country, it would be the third highest populated country in the world. In India, 20% of all diabetics would have some amount of diabetic retinopathy. And the important thing to note is that after 20 years of having had diabetes, a type 1 diabetic would have almost 100% diabetic retinopathy. And in type 2, the prevalence would be around 60%. So 60% of all diabetics after 20 years having type 2 would have some amount of diabetic retinopathy. So it's extremely important to recognize and manage this condition appropriately, because a diabetic has a 20 times more chance of becoming blind as compared to a non-diabetic. Now, whenever you see a diabetic patient and you see retinopathy like this, the first thing is to ask the patient to get his baseline examinations, the blood sugar, the blood pressure, and the lipid profile. I would also like to add hemogram to this, because anemia is another, uncorrected anemia is another cause of increase in retinopathy. So these are the parameters that you would aim for. And HbA1c, many patients will say hamari sugar controlled hai, but when you ask them to get an HbA1c, it would reflect the true picture. So every diabetic, do ask them to get an HbA1c. And this is with systemic control alone. You see all the lesions have disappeared after 1 year because the patient came back with good control. Now, a follow-up of diabetic patients, this is the follow-up schedule. So annual follow-up if the patient has no retinopathy. For a mild retinopathy, every 9 months. For a moderate NPDR, would be everywhere. You just have a few microaneurysms scattered here and there, would be 6 months. Severe NPDR, where you would have microaneurysms, hemorrhages in all 4 quadrants, would be every 2 to 4 months. If a patient has macular edema, then 2 to 4 months. For a PDR, again, a close follow-up is needed. And once you've treated a PDR, then also every 6 monthly or annual follow-up is very important. So a patient with diabetic retinopathy, you should always do an OCT, except when you feel that the fundus is absolutely normal. But otherwise, whenever there are any lesions, an OCT is imperative to identify the macular edema and also to identify vitreomacular interface abnormalities, which you would very commonly see in these diabetics. Now, most of the times, only OCT, I mean, we all do OCT has become the diagnostic instrument of choice. But an angiography would help you to detect the areas of capillary dropout, to know how much ischemia is there, to identify any new vascularization, something that you cannot identify with your naked eye, and also to detect the ischemia at the macula. That is a very large or distorted FAZ would give you a hint to the visual prognosis of the patient. So this is a patient of ischemic maculopathy, and you see when you've done the angiography, you see that there is hardly any circulation over here, and this is a patient who would not get good vision in spite of all your treatments. Also on OCT, whenever, like I mentioned before, whenever there's any disruption of the ellipsoid zone, these are the patients who would have a poor visual outcome. Also drill. So drill is a disruption of the inner retinal layers. So here you see all the retinal layers. You cannot make out those different lines in between the retinal layers here in the central part. So that is called drill. And again, drill is a negative prognostic factor. So once you do an OCT and you get all these features, you have to inform the patient that I'm going to treat you, but do not expect a very, very great increase in your vision. Now, the definition of central, we all studied about CSME, and this definition has now evolved over time. And now the definition requires the foveal center to be involved. So this was the CME, this was the definition, the classic definition of the CSME that we studied. But now we speak in terms of central involving and non-central involving diabetic macular edema. So this is the only part of the CME that comes in the central involving, that is an area of retinal thickness within 500 microns of the fovea. So this is central involving, and anything else apart beyond 500 microns would be non-central involving. So if the edema is non-central involving, that is away from the fovea, then laser still has a place in the treatment of these patients. So here you see non-central involving edema, you could do a laser. This laser could be focal, where you only laser the microaneurysms, or it could be a grid laser where you do a mild laser to the entire thickened area. And in macular edema, non-center involving is one indication for laser. For a center involving DME, the treatment of choice is injections, anti-VEGF injections or steroid injections. So generally we would start with anti-VEGF injections. You could give 3 monthly injections and then give them as and when needed. There are different treatment protocols. There's no standardized protocol. Every surgeon has his own way of treating these patients. You could give them as and when needed. You could do a treat and extend regime, or you could give 3 injections monthly in the beginning and then follow them up. So this is a patient pre-injection and post-injection. We now have so many anti-VEGFs in our armamentarium. The stronger anti-VEGFs like Eylea and Vabysmo, the new generation anti-VEGFs, they work much better and have a more sustained effect. You could also do a combined approach in patients who are not resolving, where you give them anti-VEGF and then do a bit of laser. So sometimes you may not have as good an effect with one anti-VEGF, and that is the time you switch anti-VEGF agents. In patients who have a very large edema or a chronic edema with large cystoid spaces, steroids work excellently in them. And also patients who are not responding to anti-VEGFs, or you feel would not have a very good follow-up, then dexamethasone implant works very well for those patients. When to stop injecting, either the vision improves or the foveal contour returns to normal and you see no thickening, there's disappearance of the cystoid spaces, or there is no further improvement. That is, there is no further decrease in the central subfield thickness and there's no visual gain. Now, once the patient is not improving, you can just follow up the patient. A small amount of fluid sometimes can be tolerated. And, but these patients have to be closely monitored every 3 months and inject whenever the vision goes down or the edema increases. Now, whenever you see a patient with severe NPDR, that is, a patient does not have new vessels, but he has hemorrhages, microaneurysms in all the 4 quadrants, venous beading, venous looping. So these are the patients that you have to follow up very closely, because a lot of these patients will develop PDR in the next 1 year, so you have to follow them very carefully. Now, in severe NPDR, there is always the question, should we laser these patients or not? If you feel the patient would not be able to come for a follow-up, also is pregnant, then you can subject, or is not very well controlled, you can subject these patients to a laser photocoagulation. And, for a proliferative diabetic retinopathy, like always examine the patient with an indirect. So if you see the patient on 90D or a direct ophthalmoscope, you see this is the central area which appears absolutely normal. But here you see that the patient has a proliferation. So an indirect examination is extremely important in all diabetics. Sorry. Also, patients would come with floaters or cobwebs or streaks, and sometimes you will not be able to see the hemorrhage, but if you look inferiorly, always examine the inferior quadrant very well, because there you'll see sometimes very subtle hemorrhages. And all hemorrhages in a diabetics does not equal to a neovascularization. Many of the diabetics have a PVD, and the vitreous is very sticky in these patients. So PVD can also induce hemorrhages in these diabetics. And not all hemorrhages doesn't equal to a neovascularization, and you can do an angiography to confirm. So these are some pictures of a PDR. Now for a proliferative disease, laser is still the gold standard. You can give anti-VEGF injections in some subset of patients, or you can give anti-VEGF along with laser, but laser is the one which works for a pretty long time. And laser you have to do in multiple sittings. Do not do all your laser very aggressively at the patient, otherwise the patient will come back with complications like exudative detachments, choroidal detachments. So this is a picture pre-laser, and you see post-laser, the new vessels have disappeared. Like I said, the laser should be done away from all these areas or the fibrous areas. Never do your laser very close to these. You always keep a margin. Otherwise, when these regress, they could cause a break in the retina. Now, another question that is very frequently asked is that when a patient comes with vitreous hemorrhage, should we give him anti-VEGF injections or not? So a patient with vitreous hemorrhage, the anti-VEGF injection is not going to make the hemorrhage go away, but it will prevent further rebleeds. So this is what you have to tell to the patient. And before injecting, it's very important to rule out any traction. So you can do an ultrasound. If you can see through that hemorrhage and you see that there's no traction, only then should you inject an anti-VEGF. Otherwise, do not inject anti-VEGF because it can cause a crunch phenomenon. It can cause that traction to increase. Sometimes it can also cause breaks in the retina. Another question is that whenever there is PDR with diabetic macular edema, what should we treat first? So always treat the macular edema before doing your pan-retinal photocoagulation, because if you do photocoagulation before, then the macular edema could increase. So ideally, you should be treating the macular edema before you do your laser photocoagulation. Patients who are not amenable to laser, so these are the categories of patients, like patients who have a large vitreous hemorrhage which is not resolving. They have PDR despite your lasers and your injections, the PDR is still persisting. Whether there's a tractional retinal detachment at the macula or near the macula, a combined detachment, or vitreous hemorrhage along with neovascular glaucoma, these are the patients who should be taken in for pars plana vitrectomy. So these were just some, diabetic retinopathy is a very, very vast topic to be covered. I've just tried to cover a few common questions and given you a few pointers, and I'd be most happy to take questions. So my final points are that metabolic control is very important. For a macular edema which is central, anti-VEGFs are the treatment of choice. For a non-central laser, you can still do laser. A severe NPDR, you can laser, provided if you feel that the patient will go into proliferative stage, it cannot come for follow-ups. For a PDR, pan-retinal photocoagulation combined with anti-VEGFs can be done. And whenever there is a tractional detachment or a non-resolving hemorrhage, then vitrectomy is the treatment of choice. And also systemic control is extremely important. Thank you.
Thank you, Dr. Tinku, for a very extensive topic you have covered in 8-10 minutes, and I hope everybody must have taken few take-home points. Any question from the audience?
Hello. One question is there, myself. You said that less than 10% decrease in subfield thickness is an indication for stopping anti-VEGF. So after what number of injections we should stop? After three?
Three.
Or we have to see on PRN basis?
Generally, when you've given 3 injections, you've given 3 monthly injections, and you feel, or you
whatever the anti-VEGF may be.
Whatever the or you've switched the anti-VEGF, and still you're not getting a good response. The patient still has maintaining that same edema after switching also. So it's not that you have to have a completely. What I meant to say was that many a times you will not have a completely dry macula, but if the patient is maintaining his vision and you feel that little edema is not going down, you can follow up the patient also.
Thank you.
That's what I meant to say.
Okay, next we have Dr. Abhilash.
Just the role of IVTA.
IVTA, yes. So the dexamethasone implant we would prefer because there's less chances of IOP rise in cataract, and of course those visually disturbing floaters that you see with IVTA. But it is an expensive proposition, so in patients who you think will not be able to afford, IVTA is an option. But you have to tell the patient that he will be seeing floaters, and you have to call these patients up for IOP monitoring.
Next we have Dr. Abhilasha Baharani. Dr. Abhilasha is a senior consultant and uveitis specialist at the Retina Eye Care Institute in Hyderabad. She's also the South Zone representative to the Uveitis Society of India and editor-in-chief of the very reputed USI newsletter. She will be speaking on a very important topic of cataract surgery in uveitic eyes.
Thank you very much for the kind introduction, and I thank Dr. Tinku Bali and the scientific committee for this kind opportunity. Slide is not moving. Yeah. So cataract is the most common surgical indication in uveitis. It accounts for 40% of visual loss. 1.2% of all cataract surgeries are uveitic cataracts. About 60 to 80% achieve a best corrected vision of better than 20/40. However, the post-op best corrected vision is 1 to 2 lines worse than non-uveitic eyes. What is the pathophysiology? The deranged metabolism due to diffusion of toxins through the posterior capsule leads to the cataract. So the lens derives its nutrition from the surrounding intraocular fluid, and when there is uveitis, through the posterior capsule, toxins might enter, and that is why you see the posterior subcapsular cataract as the most common type. In this talk, I'll be covering preoperative assessment and preparation, intraoperative challenges and techniques, and postoperative complications and management. Many a times, this is the eye picture that we see, and at this point, it's always important to do a B scan and look for any vitreous inflammation. Even if the vitreous is quiet, always look for choroidal thickness, because a thickened choroid might indicate an active inflammation in the eye. Assessment of visual potential, look at the optic nerve. This is a case of unilateral multifocal choroiditis with optic neuropathy. After healing, we see that there is a subtle disc pallor in the left eye. You see there is a disc pallor in the left eye, and when you do a visual field, you see a central scotoma. Many a times in cases of intermediate uveitis, while we are busy looking at the snowballs, we might miss the optic disc. Now here you see that the optic disc, there is a notch, and the patient has glaucoma. So all this assessment should be done prior to cataract surgery. Macula is the most important part, we all know. So look for a scar, a CME, an ERM, or even a macular hole. So when the media is hazy, as much as possible, now we have very good OCT machines. Always get an OCT done before planning cataract surgery. Now, hypotony is more difficult to manage than increased IOP. So intraocular pressure less than 6 millimeters, even when the eye is quiet. When there is occlusio pupil with normal IOP, always suspect that these patients might get hypotony post-cataract surgery. In children, people with white cataracts always get UBM done and look for ciliary body fibrosis and bands. And when they are present, please plan vitrectomy and not just plain cataract surgery. Hypotony can also occur in patients with poorly controlled inflammation prior to cataract surgery. Now, timing of surgery is most important. The eye should be quiet for 3 months. If fundus is visible, wait for as long as possible for full control of inflammation. Early cataract is indicated when you want to examine the posterior segment and when the cataract is very advanced, because it might lead to surgical challenges. Counseling, please counsel the patient about the visual prognosis, that the surgery might take longer. It's not a 10-minute surgery. Possibility of delayed visual recovery. Patients have to be insisted that they must continue their systemic tablets, because they might think after cataract surgery they do not need to carry on with the tablets and they may not come for follow-up. Many of these patients are young and they should be told about the need of reading glasses post-surgery. So etiological diagnosis is very important to control preoperative inflammation. About 83% of uveitis patients have an associated systemic disease. So unless we have an etiological diagnosis, we can never control the intraocular inflammation. So absolute and long-lasting control of ocular and systemic inflammation predisposes uveitis patients for satisfactory results. Coming to prophylaxis, now steroid prophylaxis is recommended in those who are at risk of macular edema or recurrences or hypotony, like in cases of VKH. Systemic immunosuppression should be stepped up 1 month prior to surgery, and this is the preferred approach. Oral steroids, if you are starting, please start at 1 milligram per kg, starting 3 days preoperatively, tapered to preoperative levels at 1 month. Local steroids should be best avoided in the absence of an etiological diagnosis in case you have to proceed with the cataract surgery. Some infectious uveitis also have a propensity to reactivate after surgery, and these are toxoplasmosis and herpetic uveitis, and prophylaxis should be started for these conditions prior to cataract surgery, 1 week prior to cataract surgery. Now the choice of surgery is obviously phacoemulsification, but because it causes less inflammation. When cataract and glaucoma both are present, cataract should be done first, because if glaucoma is done first and cataract is done later, the inflammation from cataract surgery might fail the bleb. When cataract and retinal problems coexist, a combined surgery can be planned. Anesthesia is surgeon's choice. I prefer subtenon anesthesia with a 23-gauge single-port cannula. So in this video, I'll just show you. Just enter the subtenon space, and with the single port cannula, you can inject the lignocaine bupivacaine combination. Now, intraoperative challenges. These patients present with small pupil, shallow AC, posterior synechia, peripheral anterior synechia, pupillary membranes, and zonulisis. This is So this video, this is one eye of the same. I'll show 2 eyes of the same patient. So the first eye, I have used iris hooks. So you release the posterior synechia, and under subtenon block, I'll be inserting iris hooks. Here, you need not make a very long tunnel for the hooks. A short tunnel is enough. The hook should be inserted and tightened sequentially, not all at once. Because if you tighten all at once, it can cause large sphincter tears. I generally prefer a diamond configuration, because if you do with a square configuration, there is tenting of the iris when you enter with the phaco probe. A large capsulorhexis should be done. Phacoemulsification is not very difficult in these eyes. Removing the iris hooks is also very straightforward. While removing the viscoelastic, please take care to remove the viscoelastic even from behind the IOL, because retained viscoelastic can cause further inflammation in these eyes. So removing the viscoelastic thoroughly from the bag and closing the case. Complications of iris hooks. Iris hooks should be inserted and removed very, very meticulously. Here you see the iris hook has caused a puncture in the anterior capsule, and there is mushrooming of lens fluid. Here again, see the iris is tented in a square configuration, and the sharp chopper has hit the iris here, and then you see there is bleeding, and the entire surgery gets complicated. Remove the iris hooks carefully. if you see in the third case now, while removing the iris hook, a small tag of the iris is pulled out. So please take time during these surgeries. Coming to the second eye of the same patient, here I have used the B-hex ring. In a B-hex ring, you have to release the posterior synechiae. Stretch pupilloplasty has to be done. Insert viscoelastic above and behind the iris. B-hex ring has a little learning curve, but it's a very good procedure. I don't have any financial interest. It has flanges and notches which have to be inserted in the pupil, and again removing is also very straightforward. Once you learn the procedure, it's very easy to do. And again removing the viscoelastic thoroughly from behind the IOL. So comparison between iris hooks and B-hex ring, pupil size and shape are almost the same, but shape is better for doing rhexis. There's a slight learning curve with B-hex ring. Surgical maneuvers are easier with B-hex ring. Surgical time is also shorter, and post-op pupil shape and size is comparable, and post-op astigmatism is also comparable between the two procedures. One question that is often asked is PI or no PI. So clear corneal phaco with large capsular rhexis without surgical PI is the preferred technique, but in pediatric uveitic cases, PI helps because these children have a tendency to develop glaucoma later in life. Acrylic IOL or heparin surface modified PMMA IOL are preferred. Multifocals are best avoided. IOL or no IOL, post-operative aphakia is associated with better long-term visual prognosis in children less than 5 years. But there are studies which have shown that good control, intraocular lens is not a formal contraindication, and about 80% eyes achieved a visual acuity of better than 6 by 9.5 when uveitis was quiet for at least 6 months. So post-operative complications and management, aggressive topical, oral and periocular steroid should be given, plus topical NSAID should be given. Posterior synechiae and pupillary membranes can be avoided by keeping the pupil mobile. The principle is to over-treat and relax and not under-treat the inflammation and then try to catch up later. You can also have cocooning of the intraocular lens if the inflammation is not controlled. Capsular phimosis is also a common complication, but all this can be avoided with a large rhexis. Hydrophobic intraocular lens are preferred, and there should be meticulous removal of the viscoelastic. Post-operative CME, it's the most common complication. Incidence of CME in uveitic eyes with well-controlled inflammation is comparable to non-uveitic eyes. The risk is 6.7-fold higher in eyes with a history of previous CME. Behçet's is the most common etiology associated with CME, and the mean period is usually 7 months post-operatively. So at 6 or 7 months post-cataract surgery, be very careful, be very vigilant, and risk can be reduced with post-op NSAIDs. So to summarize, etiological diagnosis of uveitis is essential for controlling the inflammation. The timing of this surgery is important. Counsel the patient about visual prognosis. Plan the surgery to avoid, to manage the intraoperative challenges, and better post-op care can reduce the risk of complications. Thank you.
Thank you, Dr. Abhilasha. You've given some excellent pointers and shown some excellent videos on how to manage these patients with uveitis. Any question?
If you have got CME, so how do you treat that?
Okay. Thank you for that question. It's a very important question. So post-operatively, if you have a CME and it is a non-infectious uveitis, initially you can give the patient a topical non-steroidal anti-inflammatory nepafenac for 1 month and wait for a month. You can step up the systemic immunosuppression. If the patient is, suppose, say, mycophenolate 2 gram per day, please make it 3 gram per day while monitoring the counts. If at 1 month also you see that there is fluid or there is subretinal fluid, then you can plan a posterior subtenon or an intravitreal dexamethasone.
So you said that in uveitic cataract you start steroid, oral steroid or whatever it is, so 3 days before surgery, and it maintain it till 1 month post-operatively. Uveitic cataract, now quiet and calm eye, the cataract is there, now there is no uveitis. still you start steroid, or without steroid we can start?
Sir, if the patient has been quiet for the past 3 months, and if he is taking any non-steroidal systemic immunosuppression, you can step up the immunosuppression. Suppose the patient is on methotrexate, then you can increase the dose of the methotrexate. If you are not, if you cannot increase the dose because patient had disturbed liver functions in the past, then you can add a steroid. If you are sure that it is a non-infectious uveitis, then you can even give a local steroid. Okay, and if you are not very confident whether it is infectious or non-infectious and you are still going ahead with cataract surgery, then you can start the oral steroid. So then you can start 3 days before and then taper down to 1 month post-operatively, provided the patient is already on some form of systemic immunosuppression preoperatively.
I think he meant to ask that in a patient who's been quiet for a pretty long time and has a history of uveitis much in the past,
Even then we
need to start
steroids. Yes.
Any patient who's had an episode, it's a good idea to start.
Very nice talk, Dr. Abhilash. I was just asking, in a hypotenuse eye which still has some visual potential, how much steroids do you give? How long to support the intraocular pressure? Let's say you're giving topical, you're giving subtenons, oral. How high do you go, and how many months will you keep carrying on before you really give up and worry that it's going into phthisis?
This is post-operatively you're asking, ma'am?
No, in general actually. It was not necessarily post-operative.
Okay. See, for hypotenuse eyes with some visual potential, it is better to keep them on some form of topical steroid as well as systemic steroid. So systemic steroid, the dose should not exceed more than 10 milligram per day, because then you are putting the patient at risk of osteopenia and all the other complications of steroids. So 7.5 milligram the body itself makes every day. So you can give about 7.5 milligram oral steroid with maybe once or twice daily topical steroid and maintain the intraocular pressure. And when you think that the intraocular pressure is maintained for 3 months and there are no ciliary body membranes, you can plan cataract surgery. If there are ciliary body membranes present, you can plan vitrectomy with pars plana lensectomy in these
But let's
eyes.
say it doesn't pick up in 3 months or something. What is the time frame after which you would give up, if there's still a little visual potential left?
No, don't give up if there is visual potential.
Then you give it
Yes.
indefinitely.
Yes.
And what is the lowest pressure at which you would operate? Let's say a eye with cataract has a pressure of 6 to 8 millimeter mercury. Would you operate the cataract at that time?
No, I would not operate. Because post-operatively these eyes might go down to really 2 or 3, and then it is very difficult to bring them back. So it is better to, if you control the inflammation, I have seen over a period of time, these eyes do come up to maybe 10 or 11, and then you are more confident in touching these eyes.
So you would not do below 10, you're saying? That should be a cutoff for us.
Yes.
Okay, thanks a lot.
Thank you.
One implant works very well if you give a prior to
Yes,
push up the pressures.
before surgery, but
Yeah.
then again after 3 months, it is better to see these eyes. It's better to follow these eyes for at least 6 months and see the pattern, how they are behaving. I generally don't operate if I see a patient for the first time with a cataract. So you see how the eye is behaving and then take a call.
For how long you keep these patients on cycloplegics post-op?
As if the inflammation has been well controlled before surgery, it's 1 week.
Okay.
Yes.
But we have seen patients, if we are taken off homatropine or atropine, there is tendency to flare up.
So that means the inflammation had not been under control in the first place. So cycloplegics will definitely not help controlling the inflammation. We need to step up the systemic treatment. Yes.
Good afternoon, everyone. Ma'am, increasing the dose of methotrexate, does it will not lead to increased chances of endophthalmitis because more risk of infection?
With local steroid, you're asking?
No,
sir?
he's
With
asking.
immunosuppressants, we
Immunosuppression.
No. See, when we are giving systemic non-steroidal immunosuppression, they target only a specific set of white cells. Steroids cause global suppression of the immune system. And because the eye is anyway an immune privileged site, we are not depending on the systemic things for, to control the inflammation in the eye. So we are not increasing the risk of end-off. End-off risk increases just like for all other cataract surgeries, like if the surgical time is long, you had a complication, all those things can increase the risk of end-off, but not these drugs per se.
Thank you, ma'am.
Thank you.
Thank you, Dr. Abhilashan. So I would now like to invite Dr. Ashish Lal. He's the Director and Senior Consultant at Lal 2020 Eye Care, Gurgaon. He's a long-term LV Prasad Hyderabad Fellow. And besides being an excellent clinician, he is also a great academician. So today he'll be talking about intravitreal injections, how anterior segment surgeons can add it to their practice.
Good afternoon, everybody. First of all, we've been listening to all the common macular pathologies, the common posterior segment pathologies for the last 1 hour. Now, my question is that what can we do in practice for them? The intravitreal injections, how can an anterior segment incorporate in his practice? We all are good cataract surgeons. We all have OCT. We all have a fundus photo. We need to understand the disease, the common ailments, why refer. The technique is simple, easy to master, good money and good results. So my talk will be in 4 parts. The first part will be the technique, then the type of injections, then when to give, and common protocols when to repeat. So you need to understand that just giving the injection is not good enough. You need to understand when you should give, how long you should give, and what all protocols you need to understand. So whenever we talk about the diseases, we talk about 3 diseases. First is the vascular disease, where the vascular permeability is an issue, like a central retinal vein occlusion, branch retinal vein occlusion, or a diabetic retina. Then we understand the choroidal diseases like IPCV or choroidal neovascular membrane. Dr. Tinku has very nicely shown how to differentiate between a vascular disease and a choroidal disease on OCT. And finally, the emergency situations like endophthalmitis. So we need to do a thorough pre-injection assessment, OCT, fundus photo, and decide whether we want a single patient vial or a multiple patient vial. I would recommend a single patient vial is more, it is much better because it is more safe. We are using it for 1 patient, so anything if happens wrong, it will happen in 1 patient only. So this is a step-by-step, intravitreal injection technique. We open the pack. There's a thick needle that is there, because this is important because we are going to take out 0.05 ml of the drug. So once you just clean up the center, this is how you take out the drug. You remove the air, then use a 30 gauge needle. This is from the outside. You have to very well understand that it is 3.5 mm from the limbus that you have to go. If the patient is phakic, then again you have to be more careful. If the patient is pseudophakic or aphakic, then 3.5 is, you are not going to harm the lens. This is how the thing is done. You have to give the injection right into the center, into the core. You don't even need to see the needle, the opening of the needle. So once this is done, this is how the surgeon sees through the microscope, 3.5 mm. Now you can see we are marking it with our caliper. We just, this is how the needle goes inside, and you can see the gush of fluid going inside. You have to put it only 0.05 ml, and then you can just close it. And this is again from the, now the site of injection is not important. Whatever is comfortable, wherever you feel that you can easily take the injection, because there are patients who are going to see on the upward direction. There are patients who see in the downward direction. Sometimes it is not very easy to do it in a particular quadrant. So whichever is more visible, you can do. So this is another video of Ozurdex injection. This is a steroid implant. Now this you need to be little more careful. need to first mark, and then this is a thicker needle. You have to go in a slightly slanting direction and then directly into the vitreous cavity, and then just take a swab and finish it off. So this was one patient who was referred to me by an anterior segment surgeon who had actually injected a Ozurdex implant inside the lens rather than into the vitreous cavity. So we did the phacoemulsification. This was a diabetic chronic macular edema patient. And once we did it, we put the lens, and then I actually shoved the Ozurdex implant into the vitreous cavity because I thought there's no point in removing it. It should work. The steroid that was given because of the chronic macular edema should work. So when we talk about injections, we are talking about, we need to understand that we have an anti-VEGFs, the regular ones, which can be an Avastin or Zydus, or a single dose ranibizumab injections like Eccentrics, or Indian biosimilars like Razumab, Osiva, Macubrite. And then we have come up with new injections, which is like a VEGF trap or a decoy receptor like aflibercept, known as Eylea. And now newer anti-VEGFs have come like Pagenex, brolucizumab, faricizumab, and implant steroids. Now, as anterior segment surgeons, we need to understand what is the difference between them. If we look at these, the ranibizumab has been used for last few years, and you can use this Eccentrics injection, which is by Novartis, and it works very well. It is also not very heavy on the pocket, and in case you want a lesser problem on the pocket, then there is Indian biosimilars like Razumab, Osiva. Now these injections work very well for most of the indications, but if you can go in for a better anti-VEGFs, there is aflibercept, known as Eylea, and now newer things like Pagenex and faricizumab has come up. Now Pagenex is very excellent. It does an excellent drying of the fluid, but there is a small concern about vasculitis in 1 to 4% patients, so you need to be a little careful. Faricizumab is something which has come up very, for the last 2-3 months only, and this is also working well because it has a more efficient way of working. Another important aspect that I would like to tell you is that Eccentrics and all these injections, the company has come up with the various financial schemes to help the patients. So for faricizumab and Eylea, they have said that if you take one injection, the second injection will be free. So you can just take the procedure charges. So ultimately, if you look at the multiple dosing over a period of an year, most of these injections come out to be little similar. So that also you need to understand. Indications, as I've already said, these are the vascular causes, choroidal diseases, and the inflammatory causes. So we've already discussed them. For a CRVO with CME, as you can see in this picture, we have given an injection, and post-injection the fluid has decreased. So when we talk about the protocol or the algorithm, as an anterior segment surgeon, you need to understand how many of them you have to give. For a vascular occlusion, 1 to 3 doses of these injections at 1 month interval. Repeat OCT every month. If fluid comes back or is still there, repeat injection. If after 2 or 3 injections again the fluid is there, then you need to give a Ozurdex injection. So this protocol, if you remember, then you can easily treat your vascular occlusions. Then comes the diabetic macular edema. Dr. Tinku has very nicely explained you the nitty-gritties about diabetic macular edema. In short, if you have macular edema, diabetic macular edema, you can give all these injections. Normally, what is recommended is 1 monthly injection of Eylea or ranibizumab till drying occurs, and for maximum of 6 months, and then a maintenance dose every 8 to 12 weeks. This is the protocol that is usually followed across global protocol, but in India we usually take it for 3 months, and once it is chronic we can give Ozurdex injection, and we also need to understand that this can be exacerbated by cataract surgery, wherein Ozurdex helps us. Then comes choroidal neovascular membrane. If the choroid is involved, now you can see this patient in one eye, you can see there is a scar, the yellowish scar is there. The visual acuity in this patient is less than 6/60, while the other eye, the the CNVM has just started to develop. So this is the left eye, wherein you can see that there is a lot of fluid here, and we have been giving injections. What I want to tell you is that for any CNVM, if the patient says that, you know, how long I have to give, you have to tell them that a CNVM will have a black shadow in front, and in case we give injections, that black shadow will go down and he will continue to see better. Once the vision goes beyond 660 and you can see scarring on the fundus photo and the OCT, then you can stop. So you can say that the natural history of the disease is what we are progressing. So if the patient, we do not give injections, then the patient will have this problem in 3 months. So if we give injections, he might, you know, continue to see for 3 years or 5 years or 10 years. I think my time is over, so I will not, to finish, the 3 loading doses at 1 monthly interval for choroidal neovascular membranes. Then treat and extend. As the name says, first treat, let the fluid go down, let the vision stabilize, and then just give 1 more so that it is extended. And then as and when required, we can also use Progenics. So learn the indications, make algorithms disease specific, what to see, when to inject, and in which disease to treat. After a month follow-up, review the disease, re-inject if fluid decreases, but not completely. Thank you. I'm not going to talk about this endophthalmitis because for short of time. So intravitreal injections are like cataract surgeries. We all should know the technique, the indications, and obviously how to follow these patients. Thank you.
If you want, you can talk about, we have a bit of, I think that will be useful to the...
Okay.
Yeah. Are you okay to, I think you can cover it.
There's a small video for a minute. This is any patient who has, endophthalmitis and you want to give the injections. This is one thing which you can actually learn to master. Nowadays, there is 23 gauge vitrectomies. Just give two trocars and put a cannula from one side. You can see you have to see the center. Just go in. Now this is core vitrectomy. You just go in with a cutter. As an anterior segment surgeon, you can actually do it. Just see the opening of the cutter and just use it for 3 or 4 minutes. Just keep on doing it there. And then do an AC wash and an AC clearing. Take the sample. Once you've done this clearing, you can see I'm doing core vitrectomy for a few minutes. And then I'm giving my intravitreal injections. Now, since it's a valve cannula, so the injection will not come out. I usually give 3 injections. We can talk about it in some other forum. But yes, once these are given, you can remove the trocars. Now, the important thing that as anterior segment you need to understand is that we need to just debulk a small part of vitreous. Vitreous is almost 4 ml. If you talk about the volume of vitreous, we can remove 1 or 2 ml by just a core vitrectomy for 3 minutes and then give the right kind of antibiotic. If it works, then our endophthalmitis is going to be cured, and we can actually create wonders by just doing a small procedure. Thank you.
Thank you, Dr. Ashish, for that excellent update on intravitreal injections. I invite questions from the audience.
Sir, I have seen you giving the injections while betadine is still there, povidone is still there in that part. So usually we wash out that and directly give it. There is no problem, right?
No, I don't think so there's any problem, but usually what we do is that first we put a drop of povidone iodine and then we wash it and then we give it.
Oh, yeah. In all your videos, without washing, you just directly gave to that povidone iodine.
It's better to wash it so that you prevent any inflammatory reactions. Point well taken.
My second question, you have given so many injections, so you are a master in that now. I want to know what are eccentrics and biosimilars. Have you got some difference in
No, I think it works excellent. Both the things work, but just the financial aspect. In fact, eccentrics has also come up with a wonderful scheme in which they say that give 2 injections and then third one will be free. So if the patient is ready for a multiple dose thing, then even eccentrics is financially similar to the biosimilars. Biosimilars are working wonderfully well. 0.05 ml. So it is not recommended because of 2 reasons. One is the IOP increases, and this is good enough for the disease that we use. 3.5 millimeter away from the limbus. Sir, usually it is 3.5 ml for anything, but 3.5 ml for phakic is very important. For pseudophakic, you can even come to 3 ml. 3 mm.
Very nice talk, Dr. Lal. My question was for the whole house actually. Is there any tips or tricks for that stubborn, that hard exudate, which is not responding to anti-VEGFs or to steroids and is just sitting under the fovea? Contour is good, but vision is not coming back. What do you do?
So for such patients who have plaques of hard exudates at the macula, generally the dexamethasone implant works very well. You could also in conjunction start the patient on lipid lowering medicine.
Yes.
Statins, atorvastatin, or talk to the cardiologist. But sometimes in spite of everything, that hard exudate refuses to go and there's not much then you can actually do about it.
And a good systemic control also.
Yeah, there's one, it's just not going, so I thought that maybe
I think just patience, you ask the patient to control systemic control, and then with time, sometimes it takes a pretty long time, but sometimes the hard exudates disappear, but they've left a lot of foveal thinning, then again the vision doesn't improve.
Some of them can't afford Ozurdex, so one is giving IV dexamethasone along with the
for those plaques, dexamethasone works very well for those.
Okay.
Better.
So one can keep trying a couple of times, 3-4 times with the...
If there's no edema, then there's no point in trying. Just for the exudates, if there are exudates along with edema, then.
No, this person has only exudates. The contour has settled beautifully.
Then you don't
so
need
more
to
than one
inject.
steroid injection you want to try?
No, then you don't need to inject. Just keep the patient on lipid lowering medication and follow up with time. Maybe they'll go.
Thanks, Ellen.
Is there any point of giving intra IM or IV Dexona to a patient who has been operated under the cover of steroids for uveitic cataract? Additional just a stat
IV or IM.
Stat post surgery.
You can give intravitreal methylprednisolone, intravenous methylprednisolone, and that is better instead of just giving Decadron. It's very short acting. So, yeah. So
already it's patient is under control since 3 months and
I generally don't prefer. I don't know about the literature on this.
Not for uveitis specifically, because for uveitis you need a longer control eventually. So probably if you have to give something IV, that will be methylprednisolone or something. But anyway, IV shot of steroid is recommended in case you have a prolonged or a lot of inflammation. Suppose you had a complicated surgery.
Yeah.
For that you can give, not specifically for uveitis.
You could do that, yeah. I do that in a lot of my vitrectomy patients when I've had a longer surgery or I expect there'll be a lot of inflammation. Then I do give IV dexamethasone. There's no harm in giving.
So this question is for the intravitreal injections. So what complications we should be looking for after giving the intravitreal injection? We should keep our eyes open for these?
Sir, first and foremost is the infection part. So you need to actually see the patient on the next day and maybe after a week and tell him that in case there is redness or irritation, then he should come up. Usually it is very, very rare. The second thing is that sometimes, you patch the eye and you can have a corneal abrasion and that can cause pain and, patient can call up. Then there is some redness for subconjunctival hemorrhage, which is not a complication at all. Otherwise, if you have done it right, usually you do not hurt the lens and everything is good. So you can always do a good examination after a month or so in your initial days. Otherwise, we actually do not look for the area where we are doing the injections. So
yeah.
Any danger of
Yes. That is one important.
Intraocular pressure also is important.
One thing
Usually with 0.05 ml, intraocular pressure does not rise. And for any glaucoma patients, you need to be a little more careful.
Any screening for detachment, retinal detachment, required in these cases?
Post-injection?
Yes, sir.
Not exactly, sir.
Thank you.
Sir, regarding the IOP rise, a good trick would be to ask the patient if he can see the light. Sometimes on table itself, the patient will not be able to see the light. That means your IOP has shot up a lot. And that is those cases you would need to do a paracentesis. Otherwise, generally, it doesn't happen. But always ask the patient at the end, can you see the light or not?
Sir, with 30 gauge needle, it is okay. But if sometimes with a 26 gauge needle, you give that intravitreal injection, just after the injection, some amount of thing comes out. Is it vitreous or it is the injection?
No, it is mostly the vitreous. It's a vitreous wick that comes out. What you need to be careful is that you just, after you've given the injection, just try and, see it with your, with your swab stick, whether there's any vitreous or not. In case it is coming out, you just cut it with your scissors. This can usually happen, especially in Ozurdex implants, which is a thicker needle. So I would recommend only 30 gauge for the intravitreal injections, but in Ozurdex, you might have a small vitreous wick that can come out. Sir, it is always recommended to have a new needle because once you put it in the sclera, it becomes little blunt. So it is better to have a new needle. Even 26 gauge also can work, but you have to be careful. You cannot.
30 gauge is also fine,
30
sir.
gauge
30 gauge works for paracentesis. So, just the important tip I'll just highlight, while giving the intravitreal, always displace the conjunctiva like Dr. Ashish showed in his video. He was displacing the conjunctiva with the swab. And even when you're giving the intravitreal, instead of going just perpendicular, you can go a little tangential into the sclera and then turn your needle down. So that gives you a valved kind of an entry and makes it more safer. And then always use betadine at the end. Once you've given the injection, put a drop of betadine, wait for 30 seconds, wash it off. So that way you have a very safe procedure.
Even with 30 gauge, you have to go tangential slightly.
Yeah, it's better. It's better. It's not a must, but I think it's a better way to do it. It's more safer. It gives you a sealed, proper seal. Any of the panelists, anything to add?
Just want to add one more point. All these patients who have chronic multiple injections, AMD or diabetes, they eventually end up in a lot of dry eye symptoms because of probably repeated treatments and also because they are on NSAID eye drops for a very long period. So yes, many of them, not in the initial phase, but after 6 months or 8 months, they start to get those dry eye symptoms and have to be put on lubricating eye drops for a long-term basis.
And most of them are on these NSAIDs like Nepafenac. They're on those. Once you start, the patient is putting them for years together. I've seen patients come back after 2-3 years putting the Nepafenac eye drops. So you have to tell them that you have to put them continuously. So if there are no more questions, we'll wind up this IC. Thank you all for such an interactive session. Thank you so much for your attendance here on a Sunday afternoon, and hope to see you again in another conference. Thank you so much. And I thank all my panelists who have given such excellent talks. Thank you so much. Thank you, everyone.